once the surgery is done, you have to take bed rest for many days. Is that true?
No, we do not advise bed rest for any of our patients.
Some say that small cuts means minor surgery, big cuts mean major surgery and a better surgery. Is that true?
Not at all.
Chemotherapy is required, then the operation is failed.
Definitely not. Chemotherapy complements the surgical treatment.
Hello and welcome to the News Minute. This is Real Talk powered by Apollo Hospitals Chennai. Joining me today is Dr. J.K.A. Jameel, who is a senior consultant, surgical gastroenterologist, laparoscopic and robotic surgeon at the Apollo Hospitals. Doctor, welcome to the show. So, could you briefly tell us about yourself?
My name is Dr. J.K.A. Jameel. I am a surgical gastroenterologist, laparoscopic surgeon and robotic surgeon at Apollo Hospitals in Greaves Road in Chennai. Born and brought up in Chennai. Went to the UK for my surgical training. I lived and worked there for about 14 years. I was a consultant surgeon there. In the National Health Service UK before coming back to my hometown of Chennai. I came back in 2013 and ever since I have been practicing as a consultant in Apollo Hospitals in Greaves Road. I'm a surgeon. I specialize in GI surgery, gastrointestinal surgery. Basically, I deal with people who require surgery for disorders in their gastrointestinal system. I perform open surgery, laparoscopic surgery and robotic surgery depending on the indications.
So, your training, the journey that you underwent, the kind of difference that you like while you were training in the UK, and what is the difference here?
Well, I have to say it's been a fairly long journey from the time I stepped into medical school to the time I completed my GI surgical training in the UK. And surgery as a discipline has changed big time in this 30, 40 years. When we were medical students, this is going back 30, 35 years, there was only open surgery.
Yes.
We hadn't even heard of minimal access surgery. Laparoscopic surgery came into the world arena in 1985 itself. It was first performed in Germany. But in India, it really caught up in the early 90s.
Oh.
But then it was being done only for a small, select number of surgeries. But as time went on, by the end of the previous century and early 2000s, lots and lots of laparoscopic surgical procedures were being done in India. And we had reached a point somewhere around 2005, 2010, where almost every surgery inside the abdomen had been attempted and done successfully laparoscopically. And then came the robotic revolution. So you could perhaps say there's three phases, this open era and then the laparoscopic era and then the robotic era. Robotic surgery was first introduced in the US in 2000 itself. So that's when the first FDA approval came for robotic surgery. But for a long period of time, the uptake was a bit slow. Just to give you an example, between 2010 and 2020 in India, there were only about 30 to 50 robotic systems pan-India altogether. But between 2020 and now, which is 2026, in the last 6 years, the number of robotic systems in India have gone up exponentially. It is estimated that there are about 350 robotic systems in India alone. So that's a huge jump. So many surgeries are happening robotically. So surgery is changing and it's changing big time.
So you have dealt with a lot of complex gastro cases. What are the lifestyle patterns that have changed over the past few years, which have resulted in younger patients getting affected, having gastro issues?
A number of things. Younger patients, particularly the people in their late 20s and early 30s, many of them, they're very, very keen in their career and their profession, and they're working so hard. They don't take care of their health much. They don't eat on time, and some of their shift patterns are really, really bad.
Erratic shift patterns.
Absolutely. I have seen patients who come and tell me, "Doctor, I go to bed at 4 a.m. So and then my question is, at what time do you go to work? I go to work at 5 p.m. So what sort of a working pattern is that? That completely changes the circadian rhythm. So not eating on time, not sleeping on time. Yes, of course. There has to be somebody awake at night to do some essential services. There's no doubt about that. But having that as a routine pattern, on all 5 days of a week is definitely going to have an impact in your health. And then all of these adds-on that come in their dietary patterns. The fast food culture, not taking enough fiber in the diet. As a result, we see a lot of gastrointestinal problems generally. Unfortunately, we see a lot of cancers even.
Okay.
A lot of cancers. Compared to, say, 3 or 4 decades ago, we are seeing more number of gastrointestinal cancers. So it is a worrying trend.
And apart from GI cancers, what are the other issues that people face? Like over a period of time, because of these lifestyle changes, what are the common cases that you encounter?
One of the commonest problem that patients come to us, GI surgeons, is gallstones, gallbladder stones. So basically, these are stones that develop in the gallbladder, and when patients have stones in the gallbladder, they can get pain. They can get acidity type symptoms. Sometimes they can even get jaundice, fever. And the treatment for symptomatic, we call it as cholelithiasis, gallbladder stones. The medical word is cholelithiasis. The treatment for symptomatic cholelithiasis is only surgery, a laparoscopic cholecystectomy surgery. No medicine is going to make that stone go away. But patients often don't get that. They don't understand that. They think, oh yeah, if I have a stone, it'll just go away if I drink plenty of water. It doesn't work that way. So that's a common thing that we see. There are other problems as well, like GERD. It's an abbreviation. GERD stands for gastroesophageal reflux disease. Basically, it's an issue where patients have a feeling of acid coming up in the chest. We call it heartburn and discomfort because of that. It happens particularly when they've had something heavy to eat. It's a very common problem, and all of us must have experienced GERD at some time in our lives. But then if that GERD is a constant thing, and if it seriously affects the quality of life, they need treatment. They need medical attention. So these are all the. Yes, the increasing incidence of cancer is there. But in addition to that, a lot of other gastrointestinal problems like these have also increased in incidence in the last 20-30 years.
And how much of it is being ignored? Because when there is a pain, people tend to ignore it. Or when you have acidity issues.
That's right, yeah.
You drink something and you're fine. You drink hot water, you're fine.
Yeah.
Have you encountered patients who have ignored these symptoms?
Plenty of such patients. And it's the younger patients who fall in that category most of the time. They think, oh, it's okay. I'm young, so I can't be having any major problems. I'm too young to have big diseases. So it's quite understandable why they think that way, but they shouldn't be thinking that way. If there is a problem that is not getting better with whatever simple treatment that you have tried at home or a bit of tablets that your doctor may have given you, you need to have it investigated.
You work at the Apollo Hospitals. You may have encountered patients, you may have met a lot of patients from different backgrounds. Tell us about some of the patients, their stories that have stayed with you personally over the years.
There are many such stories. A cancer patient that I had dealt with many years ago. This is going back probably 8 or 10 years. And normally what we do is we follow them up for about 5 years. And then at the end of 5 years, we tell them, well, we have done all the checks, we've done all the tests, we've seen you regularly, there's been no problems so far, no evidence of any cancer recurrence. And the literature says that if a patient after a GI cancer, most of the patients, if they remain cancer-free at 5 years, the chances of them developing any cancer after 5 years, the same recurrence I'm talking about, are extremely slim. So we tend to discharge them from our follow-up. So I had discharged this patient, and then the patient comes back
10 years later?
After a while. I can't quite remember how many years, but it was a fair while, along with daughter. And when she walked into my room, I had completely forgotten that I had operated on her. They narrated the whole story. And it was so, heart-touching and so happy, emotional to when the family narrates the entire story. Because you forget, they don't forget, because for you it's just a regular routine in your professional life. For them, it's a once in a lifetime event. And so they recall all the moments, doctor, I was in this particular ward and you came on a Monday and we did this on a Wednesday and then I was. So there are many such stories like that, and it really gives you lots and lots of happiness. And we thank the Almighty for giving us an opportunity to care for patients when they are, when they really need help, and giving them hope and happiness, basically turning their fear and worry into hope and happiness is a great feeling in itself. And you got to experience that to really understand what it is like. Being a doctor, being a surgeon.
That's really great, doctor. You spoke about 3 stages of surgery, like the traditional methods, then the laparoscopic surgeries, and now it's robotic. Robotic sounds very futuristic, right? Yeah. So how much has technology changed the outcomes when it comes to doing these kind of surgeries?
With robotic surgery, we are able to see better. The precision of operating is better. The blood loss is less. And therefore, the outcome is better in many major complex surgeries. With advancement in technology, we are able to deal with more and more complex diseases. More complex diseases these days than what we were dealing with in the past, with a better outcome. And robotic surgery, we are able to, operate in areas where in the past we had difficulty operating with standard laparoscopic instruments. And because we are able to operate in a more precise fashion, the overall patient experience is better. The pain that they experience is also less, and they're able to get back to work early. They leave hospital early. That's important too. We've had patients who have had some major gastric surgeries. Just in the last 10 days, we've had a patient who came from a very far off place to our hospital, Apollo Hospital, Greaves Road, and he had a gastric surgery, which is by definition a major surgery. He was out of the hospital in 4 days. I mean, if you take the day of surgery as day 1, he was out of the hospital on day 4. No blood transfusion, just 5 holes in the abdomen. He was mobilizing out of bed on day 2. He was on full liquid diet by day 3, and he left the hospital on day 4. I mean, these kind of stories you couldn't have thought of 30, 40 years ago.
There are people who go out on Google and search for remedies. So that has become a major problem. So we have a couple of questions for you, which are basically myths. Some say that small cuts means minor surgery, big cuts mean major surgery and a better surgery. Is that true?
Not at all. Not at all. Some of the most complex and major surgeries within the abdomen can be done through small cuts. So when you make small cuts and do the operation, either laparoscopic or robotic, the operation that you perform inside is exactly the same. It is just the access which is different, which is why it is also called as minimal access surgery. So definitely not true.
So as a surgical gastroenterologist, what would you say to these queries? Surgery should always be the last option for a disease at any cost.
See, on face value, this might sound like a very logical statement to make. Surgery should be the last resort. But in reality, there are a number of pathologies, number of diseases within the gastrointestinal system for which surgery is a primary treatment of choice. Surgery has to be the first treatment of choice. So, we talked about gallstones a little while ago. If the patient has symptomatic gallstones, the treatment for it is not medicines. Treatment for it is not dietary modification. Yes, dietary modification is there, that's later. But the treatment for the pain and all the symptoms that he is getting from those problematic gallstones is surgery.
Doctor, talking about abdominal surgeries, there is this general feeling that once the surgery is done, you have to take bed rest for many days. Is that true?
No, we do not advise bed rest for any of our patients. Patients sometimes understand it that way, or rather misunderstand it that way. But in modern day surgical practice, we tell patients to mobilize as much as they can after surgery. It's all the more relevant in the current scenario because many of our patients having surgeries done laparoscopic or robotic. So with just some basic painkillers, they should be able to mobilize and get back to their normal activities at a very reasonable length of time. Staying in bed is not something that we would advise to any of our patients, simply because that comes with its own problems. So if someone has had a major surgery and is not getting out of the bed, that can cause problems like blood stasis in the legs, deep vein thrombosis. You may have heard of that. Chest infections. And staying in the bed also prolongs the recovery of the bowel after bowel surgery. We call it as ileus. Paralytic ileus is the medical word for it. And there are many things that we do to help the patient recover from paralytic ileus. One of the things is getting them to mobilize at the earliest opportunity. So most of my patients, they are encouraged to get out of the bed that very next day.
So there is also this myth, doctor. If you have gastrointestinal cancers, you should be having severe abdominal symptoms. Normal pain here and there is like fine. Is that true?
Some of the most aggressive gastrointestinal cancers can present with little or no symptoms.
No symptoms at all?
Yes. I'll give you one example. If there is a cancer of the colon, the right side of the colon I'm talking about, we call it as cecum. Patients may be feeling fine, they may be eating well, they may be going about their usual business, and when they go for a check, just a general check, the only abnormality that might come in that general check could be a low hemoglobin. And let's say this is an adult male, okay, a 35-year-old male, and you would expect him to have a hemoglobin of about 13 or 14. That's a normal. But this chap's hemoglobin is only 8, and he's surprised because he's got absolutely no symptoms. So he goes to the doctor, and the doctor he looks at it and says, well, if it's this low, it needs further evaluation. And he gets, these are real stories even. The one that I'm telling you now is the kind of scenarios that we come across. And when the investigations are done, one of the important investigations in this particular patient would be a colonoscopy. And, a telescope test through the back passage. So the scope goes all the way through the large intestine and goes to the last part of the large intestine, which is the cecum, last part from below. And there's a tumor there. And there's a cancer there. So basically what's been going on, that tumor has been slowly bleeding over a period of time, and that has resulted in the drop in the hemoglobin over a period of 3 months or 6 months. Now, yes, some patients do talk about the bowels, the stools turning blackish, which is an indicator of that slow ongoing bleeding. But many a times we see patients who have not noticed the color of their stools. So for all practical purposes, he has had no symptoms and he's got no complaints to talk about. And the only issue here is a low hemoglobin. So that's a cancer. That requires aggressive treatment. So the answer to your question is, no, not all GI cancers manifest themselves with pain or anything really sinister.
So weight loss is always good for me. No matter what, nothing will happen.
If it is unintentional, it's not good for you. Intentional, yes. If you are wanting to lose weight and you're going through a diet program or an exercise program, that's great. If you're losing weight for no good reason,
without knowing,
it means your body is trying to tell you something, and you need to evaluate it. You need to investigate that.
So there is also this general talk among people, or general perception, that any pain in the anus is just, everything is piles.
Piles can cause anal pain. That's a well-known fact. But not all anal pain
are piles.
Is due to piles.
Okay.
We have to be very clear in that understanding, because there are so many other reasons why one can get anal pain. This, the common things: anal fissure, fistula, anal cancers even, or rectal cancers which go down to the anus. These are all conditions that can cause anal pain. So to assume that my pain is only because of piles and it should get better with a bit of ointment is a big mistake.
My cancer will spread if a surgeon operates me.
Not true. If that was the case, we wouldn't be doing surgeries for cancer at all. Surgeries for GI cancers. Modern surgery has evolved so well that we ensure that the principles of cancer surgery are followed at all times. And if those principles are followed, and if the surgery is done the way it needs to be done, it can be the best component of the cancer treatment for the patient. So this understanding that if I have a cancer, I should not have an operation. An operation by itself will make the cancer spread is a gross misunderstanding, and unfortunately this misunderstanding is prevalent even today. In 21st century India, in some of the rural areas, misunderstanding is still there, and I have seen some patients fall prey to this misunderstanding and not having the operation when the tumor was at a very, very early stage, and then they basically missed the plot, and then they come back 2 years later when the tumor has spread to different parts of the body, and at that point surgical option, a curative option, is not going to be there.
So chemotherapy.
Yeah.
If chemotherapy is required, then the operation is failed.
Definitely not. Chemotherapy complements the surgical treatment. After surgery, even if the tumor has been completely removed from the patient's body, if there are certain characteristics in the tumor, which we will know when we look at the histopathology specimen, we recommend chemotherapy, and that's done by the medical oncologist. And the fact that the patient is going for a chemo doesn't mean at all that the surgery was inadequate. So we usually make these decisions as a team. It's not an individual who makes such decisions. It's a team, no? The surgeon, the medical oncologist, radiation oncologist, and so on.
So as a gastroenterologist, surgical gastroenterologist, what is your reply to something like this? If my gallstones are tiny, they generally don't cause trouble.
As far as gallstones are concerned, small doesn't mean safe. Personally, I've seen patients with gallstones as big as 1.5 centimeters, 2 centimeters, not having any trouble. I've also seen patients with stones as small as 1 millimeter, 1.5, 2 millimeters. Sometimes, they're not even called as stones, they're called as sludge. But developing severe problems, even problems like pancreatitis, and ending up in the ICU. So judging the course of a disease based on the size of the stone is not scientific.
So there are some home remedies, doctor, that Google throws up and says, drink plenty of water, your gallstones will get washed away.
No, they
Doesn't
don't.
happen.
They don't happen with gallstones, not at all.
Have you encountered some cases
Cases of
people saying we have been drinking water?
absolutely.
Okay, since you're a robotic surgeon too, robotic surgery means the robots will operate independently. The doctors will be just mute spectators. Is that how it's being understood?
The robot doesn't make any independent movement. Every movement of the robot is controlled by the surgeon. So it is the surgeon who uses the robot as a tool to perform this operation.
And my last and final question, doctor. If I'm a vegetarian, I'll be completely disease-free. As a surgical gastroenterologist, what is your take on that?
If you are a vegetarian by choice, that's absolutely fine. That's your choice, and we have to respect your choice. But to think that by being a vegetarian, you will not get any disease, or you're immune to all disease and you will remain healthy, is not scientifically correct. I mean, as a gastrointestinal specialist, I can say, to the best of my knowledge, to remain healthy, what really matters is the kind of balance that you have in your diet. The right amount of carbs, right amount of proteins, fats and vitamins and so on. This label of vegetarian or non-vegetarian don't really matter.
Thank you, doctor. Thanks for joining us and giving us all your insights. Thank you.
Thank you so much, Shabir, for having me.